Welcome back to In Circulation. The podcast we're going to explore today is about the future of cardiovascular care, innovation in practice models, and the transformation happening across cardiology in general. I'm your host, Jude Hebert, Vice President of Clinical Programs at Cardiovascular Logistics. In this episode, we're diving into an exciting frontier in cardiovascular medicine. Coronary CTA with plaque analysis and fractional flow reserve, and how emerging AI models are shaping the way we practice cardiology today. We're joined today by two distinguished guests, Dr. Veronica Covalesky from our Philadelphia practice, and Dr. Lance Sullenberger from our Capital Cardiology practice in Albany. Thank you both for being here. Appreciate it very much. Before we get into the discussion, could each of you just briefly introduce yourselves and share what drew you into this area of cardiovascular innovation and imaging, and give us a little background about yourselves?
Sure, my pleasure. Thank you for the invitation, Jude. I'm a clinical cardiologist in practice in southeastern Pennsylvania for more years than I care to admit to publicly, and director of imaging, starting out with humble SPECT imaging, moving to PET-CT, and now CTA in the practice. And we're drawn to CTA because of the immediacy of the technology and also the AI overlay that really allows us to understand the disease process in our patients in a much more granular level and help us with management. And I will also admit that I am a sophomore in comparison to Dr. Lance Sullenberger, who's been at this quite a bit longer than I and has a much more mature program that I'm sure he will elaborate on.
Great. Thank you. It's really nice to be here. I really appreciate the opportunity. I'm Lance Sullenberger. I'm a non-invasive cardiologist at Capital Cardiology Associates in Albany, New York. I've been here 17 years. Before I was here, I was active duty in the U.S. Army at Walter Reed Army Medical Center. And it was there back in the early 2000s when CTA began coming to the forefront and using CT as a technology to evaluate patients for cardiovascular disease, first with EBCT. So we got into EBCT scanning, and later with multi-slice CT to assess for calcium scores, and then moved into CT angiography. It was really about 2005 that I trained and did my early training in CT angiography at the Washington Hospital Center as an extension of Walter Reed Army Medical Center, and then brought a CT angiography program to Walter Reed. One of the main reasons I came to Capital Cardiology in 2008 is because when I interviewed here, Capital Cardiology was already into CT angiography as a method for evaluating patients, which I thought was really forward thinking. It took a lot longer for payers and CMS and the world to catch up with the power of CT angiography. But now we here have a very robust program. We have two one heartbeat CT scanners that we use all the time to help evaluate for both calcified as well as non-calcified obstructive disease. I think up until about the 2021, 2022 timeframe, we thought CT angiography had matured to where it could be. At that point, we had a couple of vendors who were doing ischemia modeling on it, but it was really the overlay of AI, which has come to fruition just in the last 3 years, that has really changed the whole dynamic and helped me as a cardiologist who's been doing this now for 20 years, doing CT angiography, see the future of where CT angiography is going. It opened up a whole new world, putting AI and CT together.
Great. Thanks. Wonderful introductions to both of you. And let's sort of get into some of the topics that I think everybody's really interested in. If you guys could just discuss what coronary CTA is with plaque analysis versus FFR, and why, in your view, it is becoming a significant modality in diagnosing coronary artery disease.
I think the major change here is that CT angiography, when it started and up until about the 2021, 2022 timeframe, the major power of CT angiography was in the negative predictive value, really looking to see, you couldn't have patients with too much plaque, because if you did, you got false positives in terms of whether or not that there could be luminal obstruction, because reading percent stenosis became more difficult. And so the real power of CT angiography, when it, over the first 15 to 20 years, was really in the negative predictive value and getting a CT angiogram that showed you no plaque to the naked eye or very little plaque. And so you would know that that person did not, they just have mild plaque or they have no plaque, that their overall prognosis is good. They may or may not need statin based on the presence or absence of what you can visualize as plaque. I think the real change here has come with AI and with plaque analysis is the computer modeling can pick up plaque and the different types of plaque, be it non-calcified or low density non-calcified, or how much calcified is there, and give a cubic millimeter amount along with the percent stenosis that really changes the game. So you can have a person who may have mild plaque but has a significant amount of low density non-calcified plaque. So that person may not have luminal obstruction, but clearly is at higher risk of an acute coronary syndrome from plaque rupture. And as a human being, you also get an absolute number, right? When you're looking at this, and people like numbers. People like to know how much is there, even if they don't even really understand what the number means. If you're telling people the amount relative, the amount of non-calcified to calcified, people do understand relative amounts. So they understand why their calcium score may not be as predictive as knowing the total amount of plaque volume.
So I totally agree. And I'll backtrack. So numbers are important. And the lipid guys that have used calcium scores to target LDL, which is such a rough, blunt instrument compared to plaque analysis. And so now they're very, very interested and very excited by the ability to predict plaque burden, percent of atheroma, and the characterization in particular. And then the thought of being able to follow those folks with your treatment plan, reimaging several years later and assessing the efficacy, is making them just so excited about our technology. So I just want to harken back to 2005 when you said you were early in your training. So at that time, I was still deep in the dungeons of SPECT imaging. Graduated from planar, and really the SPECT imaging was great. But my sister, Dr. Joan Lacomas, who directs the cardiovascular program at UPMC, was spending hours, but on a 4-detector scanner, calculating and processing and reprocessing to get that anatomic data. And so one of the hurdles, and I know Jude is going to get to this in the questions later, was always that the radiologists were doing the study, that the studies took a long time to get processed, and that the information was not always reliable because of blooming and calcium and plaque burden. And so the clinical cardiologists became disenamored, right? They'd much rather go to the cath lab. We get a picture, we know what the deal is. Well, you don't really always know what the deal is there either. And we're sending lots of patients to the cath lab who really don't need to go. So this is like the birth of a new dawn, or the rebirth of a new dawn, with fancier tools that give you more precision. So your patients get an immediate answer, not just do I or do I not have it, which a stress test will never give you, right? A regular treadmill test, you can't look in the eye and say. And they get prognostic and functional information about the inside of their arteries. So it's a game changer, really just a game changer from the clinician's point of view. And with you in the driver's seat, right? Your program, you have the cameras, you make the schedule, you determine the access. You're not sharing with oncology, you're not sharing with GI. You are just imaging those cardiacs. It really does change the care and the access for our patients.
Right. And I think I just want to say, I think you really touched on something there with the ability to re-image. So, the data that's out there on anything to do with plaque, a lot of times just has to do with QCA from the cath lab, and which is, talk about a blunt instrument. I mean, that's very, very blunt. So the granular detail of what you get when you do plaque analysis through AI could open up a world where you could look at the effects of specific medications on not only plaque burden, but plaque percent stenosis, and also the relative amounts of non-calcified, low density, non-calcified, and calcified plaque, and really make a difference, not only in the patient life, but also motivating patients to see, yeah, I know you didn't want to go on a statin, but you went on a statin, and look here how much you've reduced your non-calcified plaque burden, which is the most important things. Because now, a lot of times, right, because of payers, you're using calcium scores, and most people don't understand that when your calcium score rises on a statin, it's not necessarily a bad thing, and it's not that you failed something, it's because you're calcifying non-calcified. Like, it takes a long time to explain it. But if we can get to a point, because radiation doses with these scanners are much lower, if we can get to a point where we are re-imaging, doing serial re-imaging of patients on medical therapy for non-obstructive coronary disease, we'll be able to make a real difference in terms of medication compliance and outcomes.
Right. So you'll be able to adjust your medications more appropriately. So intensify therapy, we all have these clinical cases that the LDLs are low, the patients still have progressive disease, they get in-stent restenosis. You'll be able to look and see what really is the deal there. And in other situations, you'll be able to pull back. You'll be able to say, we have you on enough drug. We don't need to add anything more. The goal line, the goal post, the goal for treatment, it is going to be visual. It'll be visual assessed by AI. It won't just be a number that is a statistical analysis that isn't personalized for you. So it really takes us into a whole different realm. Now, you and I can sit here, and Jude's nodding. He knows that you and I understand this well. We're very anxious to get it out there to as many patients and providers as we can, but we still can't get everybody there. And even when we get them there, it is a transition in the clinician's thought processes. Well, why are we doing this? Why can't I just order a treadmill? Isn't that fine, right? The treadmill's negative, they're fine. They don't have it. You can't look the patient in the eye and tell them what's wrong with them.
That's going to lead me into sort of the next questioning, which is, if you guys could explain, number one, how are you utilizing this in your current day-to-day, patient encounters, and secondarily, how does this? One physician I spoke to, who I respect, who's a senior physician, has been around cardiology for 40 years. He said, regardless of this, another tool in the toolbox to help us diagnose and treat can't be a bad thing. And I've been in cardiology now for 30 years, and I was really in the patient care realm before PET CT really came into effect. So, personally, I probably stood around and witnessed and looked after patients while they were doing treadmills and nuclear spec, and we were doing a tremendous amount of those. But you also have stress echo, which is effective. They all have their amounts of specificity, et cetera, when it comes to specifically diagnosing. And the true realm of the plaque analysis part, in my view, gives you so much more information that you can truly understand the characteristics, and you can also pinpoint and customize treatment for specific patients. Want to add to that?
Yeah, I would. I agree with that. I think that as a non-invasive cardiologist right now, there's never been, a better time. It's not like, I don't know, I trained in the early 2000s when you had, like you said, like there was stress echo, or there was regular treadmill, stress echo, or SPECT. Then CT came on board, but CT was a little more blunt. It was helpful, but not if you had too much plaque. And then PET-CT came into the mid 2015 to 2020 timeframe. And now AI has come on top of CT imaging, which has added a whole new realm. So I take each individual patient and try to figure out, what do I really need to know about this patient? Do I need to know if they have coronary disease, or do I need to know, do they have obstructive coronary disease? Because that's the first question. Because if I don't know that if they have coronary disease at all, then I'm going to lean towards CT angiography, because it's a way to tell me not only if they have obstructive disease and is there ischemia, but what's the burden of their plaque to a cubic millimeter level, and what is the subtype of that plaque. If I know that they have coronary disease, and certainly if they've had revascularization, stenting, bypass, CT is obviously not a great choice for them, but ischemic evaluation through either SPECT or PET-CT is a better evaluation. I personally think stress echo should be reserved for in the rare case where you have a patient who's nervous about radiation doses, and they're young. I can't think of another application. Maybe when you're evaluating outflow burden and HOCM, but other than that, stress echo should really be something. If you have a low risk patient, that patient should get CT angiography, because that patient, you don't want to miss. Not that they don't have obstructive disease, but that they have plaque that is non-obstructive, that you could go ahead and treat for their long-term, attenuating their long-term risk, right?
And that's a point that I make with this little insight. So I'm married to an oncologist and have been for 36 years. So the oncologist, early diagnosis and treatment is key to this. There's no statistical Bayes theorem, you're the risk, you're that. They go right to getting a diagnosis so they can look the patients in the eye and tell them, you have it, this is how bad the problem is, and this is what we need to do to treat it effectively. Or you're in really deep doo-doo and we need to do more testing. So CTA with the AI overlay is the perfect tool for that. Now, it depends a little bit. You asked the question, Jude, what are we doing for our patients in this setting, right? The ER and acute chest pain, a little bit different realm, although I know the companies are working on enhancing the algorithms so that in the emergency room, you'll be able to get a real triple rule out hopefully sometime very soon. That's a different set of patients. But for the garden variety patient who comes into your office, we are definitely pushing that payer envelope. These patients, we need to know. We can't just tell you, oh, you're fine, you did 10 minutes on the Bruce protocol, you're going to live forever, right? And in South Philadelphia, where I practice, there's two patients that have walked out and dropped dead that everybody knows about, right? So we're not going to go there. We're not going to go there. And stress echo, you're right, Lance, limited application, good tests, burden and HOCM, valvular disease, regular treadmill for chronotropic competence, those kinds of things. So you're not going to throw the treadmill away. And there are some patients who won't crawl into a PET CT to save their life. So maybe a SPECT scanner is a better tool. We do have isotopes now that are coming online that'll even allow you to do treadmill testing on your PET CT scanner. where for patients with non-obstructive disease, coronary flow capacity, coronary flow reserve have really changed the game there as well. So, all these tools, getting them out into the clinician's hands, getting to understand the value and the appropriate test to order and the information they're getting, and then that serial imaging to look at treatment impact. Now, right now, that serial imaging may be a little bit of an issue in getting coverage. I think you're going to have to learn how to be careful about, oh yeah, we knew this one was a bad lesion, but there's still residual disease in the 40 to 70% that we need to be able to assess. So, teaching about how to code and how to document your letter and how to get the plea out there for coverage, I think is also going to be important. Although the payers really do like CTA and they're starting to like the FFR and plaque imaging. We haven't talked at all about using it in the other set of patients, which is planning your interventions. Maybe you want to talk a little bit about that. I know the science there is lagging behind the enthusiasm, but
exactly. So we're expanding the use of CTA certainly into the CTO category, where you can see on these with clearly analysis where there is flow in the distal vessels that pass the site of obstruction, usually through obviously collateral vessels, which can help our interventionalists who are guided in CTO or who are advanced in CTO to guide where exactly they need to go in terms of placing the borehole and these other things that they do in the cath lab. I just want to expand something else that on what Veronica said. I mean, I think in a world where there were no payers and everything, right, we're seeing the dawn of changing from calcium scoring to CTA with plaque analysis as a way to screen those patients. Instead of doing a calcium score every 5 years to look for, do you have calcified plaque? I mean, it would be a much more obviously reasonable or better assessment to see if you have any plaque at all, based on not only the visual eye, but on AI modeling. It's just payers have to catch up with that, as does the literature. So
right. And the perfect example is the 53-year-old female executive I had with a 0 calcium score, who after COVID is so short of breath on exertion she can't do her usual 2-mile walk or do her yoga. And at that time she wasn't really excited about having too much additional testing, did agree to a PET CT, which was abnormal. And then, her cath showed a lot of soft plaque everywhere. And so she would have been ideal if she would have agreed to a CTA right out of the. But, you have to negotiate sometimes in the exam room. But she's not the only person out there with a 0 calcium score and persistent symptoms. And you don't want to get into the trap where you say, well, you had no calcium, you don't have disease. Absolutely not. Absolutely.
So Lance, you guys at CCA have been working really with Clearly for what, 3-4 years now, about or so. How do you tell us a little bit about your and this is to both of you, of course. How do you see AI really affecting the changes in cardiovascular medicine? And in my view, the AI associated with coronary CTA is just the beginning. It's really ahead of a lot of other technologies. And what are some of the other technologies that you think AI is going to influence cardiovascular medicine?
it clearly came to us in the early 2020, I think it's 2021, and they were looking for programs that did a lot of coronary CTAs because they needed data to feed their machine so it could machine learn. And so every coronary CTA we did, and we do about $3,800 a year, went to Clearly, and we got a report for free. Nobody got charged anything. It was all, below the payer. And what was fascinating was to watch the machine learn. So when we first started doing it, we'd get the report back and you'd be like, I don't really agree with it. Most of the time, the first thing you notice is this. The AI picks up on plaque that your naked eye can't see.
Yeah.
And
As the CT reader, you're saying, right?
As a CT reader, you can't see the non-calcified plaque that it will pick up on almost every scan. Not every scan, but almost every scan. To the point where you're like, is it real or is it not real? But then, you look at pathology studies and there are, fatty streaks even in 18-year-olds, and, it becomes that debate. The next thing that we noticed was every 6 months it was getting a little bit better. So at first you'd be like, I don't really agree with this one and this assessment and that assessment. Then it got to be that, like, over the course of the next 2 years, it got so much better. You as a reader would be looking at the report also while you're to see, because the reports would come back so fast, to see, did I miss anything? Like, did I miss anything as a reader? Because you start to look at the report as not only like something you're verifying, but it's sort of verifying your read that you did. And then when ischemia came out, it added a whole different level, where you not only got the percent stenosis, the type of plaque, but whether or not mathematical modeling predicts that there would be flow decrement across that lesion. So I think I learned a ton from just being a part of that experience about how good AI is at continuing to learn upon itself as it gets more and more data. I think what's next we see is, and we're sort of already into that, but echo, right? Echo AI analysis. I think PET could easily slip over into an AI analysis of not only perfusion, but obviously CFR and CFC to see, to generate answers to questions about whether or not, what the total ischemic burden is, and come out with its own report that the cardiologist verifies. And then we're at the dawn of AI. I mean, I'm starting to use AI notes, ambient AI notes, not only in the office, but using in the hospital, just because the technology's there. And I think we either have to grow and learn with it or get left behind. I mean, it's going to become a part of every part of medicine. We just have to figure out how we work with it to do what's best for our patients and our practices.
I actually think that ultimately what's going to happen is, rather than having a desktop where you're selecting the AI widget that you want to use, that there's going to be an overlay AI that's going to integrate all the information and help the clinician sort what the next best test is, if this constellation of findings warrants this particular consideration for treatment, such as an amyloid evaluation or a myosin inhibitor, or a pericarditis treatment. So it's going to take all of those things and integrate it for the provider. So I think that you're right. The providers are going to have to adjust to this. The technology has to get better. Right now, it's very burdensome. If you, as a clinical practice provider or CVL, as a platform, has to go to every single one of these vendors, sort where the value is and who the best is. And I know Jude calls me, I'm sure he calls you with questions from whoever the latest person who was pulling on his shirt sleeve at the latest meeting. But that's not the way this is going to go. You and I maybe are more sophisticated in our level of knowledge and understanding and have had the experience of watching these technologies evolve, but that's not the average hospital administrator. That is not the average, cardiology director. And so we're going to have to rely on people much smarter than us and more resourced than us to help put this together. And I've actually spoken with James Min a couple of times about this particular approach to the problem, taking the best in the class algorithms and AI, this and that, and sorting it together. Now, how that works, I don't think we're there yet, but that's where we need to be. And so having clinicians like yourself who are multimodality trained, which, speaking of, Jude, another barrier to care. My favorite gripe is that we can't train enough cardiac radiologists or radiology cardiologists or whatever you want to use. Train one a year in a program and they go to the Harvards and the Columbias of the world. And I've been trying to, bug my sister about training me one up for a long time, but they don't want to come to Southeastern. So, what can you say about that? But so that's really where I think AI ultimately is going to go. And I think it's going to happen quickly. I just know the number of calls I get from companies, each with their own little approach to a very narrowly focused problem is exploding. So that's why I think that the overlay is going to really be where we end up.
Yeah, I would agree with that. I think as this is sort of off topic of CTAI, but if I were an AI company right now, what I would try to do, I'm talking about like a Chat GPT or Gemini or something, I would try to partner with Epic or Athena or a big EMR and figure out how you integrate AI into that type of large medical record where the AI could see not, the entire medical chart, including the radiology, including the labs, including the patient visits, and then be present in the room with, as ambient technology when the provider's in there, and then generate the questions like, oh, they mentioned they had carpal tunnel surgery. I've also noticed that their wall thickness on their most recent echo is X. Did you consider testing for amyloid? And here I've prepared an order, for a PYP scan. Just hit this button, and your PYP scan will be ordered, and it generates, the prior auth for the PYP scan and everything just based on that. I mean, I think that's eventually where we'll get to. I don't, it's going to be humans and AI working together to take care of humans. So
that leads me into my next really sort of discussion topic is in my career in healthcare, I've seen a lot of changes. I mean, when I was first a nurse, Plavix didn't even exist. Stents weren't a thing. Everybody got bypassed, and that has changed drastically over the 30 years that I've been involved in healthcare, right? But as new technologies come about and things grow and there's an expansion, there's always a group that are doubters, right? So is AI moving so fast that it becomes a disruptor? Or I think both of you pointed to the fact that we really have to embrace it for what it can deliver from a patient care perspective. Your thoughts, Lance, about how, in my view, like you were describing, all it's doing is making me a better physician when I go in the room with the patient.
I think one thing is going to drive AI becoming a major part of healthcare, and that is the supply-demand mismatch. There's so much demand for medicine right now with such a low supply of physicians and even APPs that you are going to have to integrate AI in the future to be able to take care of the number of patients that are going to be demanding healthcare services. And you're either going to have to learn to use it or not. I mean, certainly in primary care where physicians are leaving in droves, you have to learn to integrate AI into the primary care model. What that looks like, I don't know. I mean, maybe it's humans interacting with some sort of interface that has AI and a physician overseeing that interface, whether it be bots or a computer screen to try to help figure out where they go. In cardiology, like we said, I think it is AI integrated into the medical record and being a part of the patient experience and helping the provider get through all the testing that's been done and all that's available and what are the recommendations based on not only clinical recommendations or guidelines, but also what is the best test based on what the testing is that's been performed before this. So I think it'll only be a disruptor if you're somebody who is not open to integrating it into your practice. I think if you're open to integrating in your practice, it'll just augment things.
I definitely agree. And I think there are good disruptions and bad disruptions. Right?
Yeah, no doubt.
So, the one I described earlier is an excellent disruption, right? You have it all put together. It's sitting in your EMR. It's helping you write your note and it's helping you make good decisions. So I think it's good. I think, it will force some people to come to Jesus in terms of, are they going to really make the change, make the effort to learn it, or is this something that they're just going to never get their hands around? And I never want to say that it's going to push people to early retirement, but I've had some days like that where I'm fighting with my note and Epic and whatever. So I think, disruption is an interesting concept. I think it does have to get more user friendly and be a little more facile for people. I think sometimes there's way too much, clicking and pointing, leafing through, and that could be smarter as well. But I definitely think that it is going to help us. And then just back to your point about the APPs, I have mentioned this to Jude multiple times. We always talk about getting them to practice at the top of their license. Well, they don't even know where the top of their license should be, right? I'm not disparaging, but we hire them fresh out of school. They've had no clinical experience, and we're turning them loose on patients. So we're really going to need to rely on the technology to help them make good decisions. These are not bad people. They are learning. They need to learn. And, that the AI and the algorithms and the workflows can definitely help that so they don't miss anything. Because even if you have a supervising physician, and there's so many of them, a number of them, it's going to be hard to keep track of without very strong guardrails. And those guardrails are going to come from AI.
So if you could give, if both of you could give some advice to physicians, young, old, etc., about ones who are hesitant to adopt these type of new technologies, what would that be?
Well, I think that one, you have to know where you're practicing, right? Because access to technology is still, unfortunately, a very regional thing. And if you only have access to it through your hospital system and your radiologist, you need to find somebody who can be your friend and help you get your patient studies ordered and make sure that you are ordering the correct study for the correct indication, right? That's also a learning curve we haven't really talked about, because it's not just about the coronaries, right? It's about all the other studies and things that we can image with our wonderful CT scanners. And then the accessibility, the availability, and being open to looking at those results and doing a little self-learning. I mean, you can get online education about plaque analysis. I mean, the companies are very, very, very generous with the resources that they have, and make sure you understand. And if you don't understand, ask questions. And then also, you may have a CTA program, but they may not do FFR or plaque. So if you're vocal about it and the more tests you order, especially as the reimbursement climate for those technologies is improving, they're going to want to get on that bandwagon to help us take better care of our patients. So I would say, know what's available, push if you need more, and if you get results back that you're not sure about, go back to the interpreting physician and say, hey, help me with this. And they are usually very generous with their time and their explanations.
Yeah, I totally agree with that. I think the major thing we've had to teach when integrating clearly and models is you, you need to understand the report. If you're the provider, be it the APP or the physician, you need to look at the report and understand what the report means that's going to the patient. Because, yeah, it's not binary. It's not, oh, there's obstructive disease and they need to go to the cath lab, or no, there's not obstructive disease and they need medicine. There are variances of the report in terms of plaque analysis that can be extremely useful um, to helping guide therapy on understanding that report. And like Veronica said, either through your online education or just talking to somebody, or asking AI, asking a open evidence or chat GPT, what does this mean?
Evidence is something I just learned about recently, and I will say for the clinicians listening, it's very helpful and very good. And it's references are cited, and they just need your NPI number, and it's free. So I'm not doing a commercial for them, but it is remarkable. So, and Chat GPT, you do have to be a little careful. It's pretty basic, but open evidence is really a marvelous tool.
And I'll plug also the Doximity GPT, which is HIPAA protected, is also good if you have a patient specific question, or
This is
you're
a
trying to.
new up to date, right?
Yeah, I know. Open evidence. I told somebody at one of the somebody said, "Oh, how do I get on to up to date?" I said, "Listen, nobody's using up to date." No offense. It's a little difficult, but if you just go to open evidence, you type your question, they tell you the answer. It'll give you the answer with references, right? Right.
I have one last topic I would like to get your input on. And in this world of, you know, economics and cost cutting and trying to really, um, payers are pressuring us, CMS is pressuring us to really be cost conscious with everything that we do. If we look in as from a value based care perspective, if I'm a payer, if you will, um, how does this, coronary CTA, AI technology really help us to, because we're really talking about, okay, another test, right? How does that really work into the reduction of costs? What's your opinion on that?
I think the hardest part for a payer is that, so there's two aspects, right? Number one would be the aspect of, do I get to avoid going to a cath lab that doesn't, that won't end up in revascularization, like diagnostic cath testing, um, should eventually become a rare phenomenon, like just doing a diagnostic cath and finding that there's no obstructive disease that needs PCI or revascularization. Um, I, I think in a broader sense, right, payers would have to look out along 5, 10, 15-year outlays, which they don't do, right? They look out 18 months. They don't look out that long. But if you really wanted to see the cost benefit, it's the patient who had a CTA, had, mild non-obstructive disease, but had a lot of this higher risk non-calcified or low density non-calcified plaque that got put on a statin, who never ends up getting PCI and MI, LV dysfunction, all the things that weigh heavily in the whole medical cost system. So,
Lance, do you also use that as justification to put them to take the next step and put them on the higher cost drugs that are coming on the market, PCSK9s and etc.?
yeah, I certainly, if somebody is on statin therapy, right, and has a well-controlled LDL, and I'm doing a CTA, I just did this on a patient the other day, had a CTA, and I was like, well, the good news is, your chest pain was not ischemically mediated, but we ran our analysis of it, and you've got a lot of, this higher risk plaque. So despite your LDL being, quote, at goal, end quote, per the guidelines, we need to be more aggressive. And I'll put that patient on a Repatha or inclisiran to try to drive their LDLs down. Some of those patients have elevated lipoprotein lipase. Some of them don't. Right now, the only thing in our armamentarium against that anyway is the PCSK9 inhibitors. So, I'll use those to try to really drive down LDL to stabilize that plaque.
Sometimes even despite those therapies, Jude, you end up with patients who still have high-risk plaque when you re-image them, right? So then they're looking at things like prediabetes or early diabetes and SGLT2, a GLP-1, colchicine. I mean, there's a whole raft of other drugs. So you're really targeting and personalizing the treatment, right? It's not this broad brush where you're just throwing the statin at them at high dose, adding the ezetimibe, and then if something else happens and the LDL was 70, because we forgot, they got changed to 55 for patients that have had something happen to them, it's much more personalized. So I'll get back to the oncologists. They scan their patients, they scan them serially, they're following the disease, they're even doing genetic analyses. We haven't quite gotten there yet, but this plaque analysis gets down so granularly to what is wrong with the patient and what they need. It will allow you to target the therapies very specifically and very much affect their prognosis. And what Lance said earlier, if everybody could have a clearly at age, whatever age you want to pick, 40, you're going to identify a lot of disease early and modify a lot of disease that won't end up causing an MI, that won't end up requiring a stent or, God forbid, a heart transplant because they had a huge infarct that they got to the hospital too late for, and their LV never recovered despite the best interventions and the best science. So, that's another nightmare, right? So this is where I can speak for Lance. We believe this technology should be used early and often in a broad set of patients to really figure it out. And you will have patients that have nothing, maybe not many, but you'll have patients that have nothing, right? So, and it's true about the radiation. I want to get back to this. The scanners are getting much better. The doses of are lowering. We do have to be careful about that. I don't want to see 20-year-old women or even 30-year-old women, getting CTAs. We have to be smart about that, right? Unless they really need it. So, imaging wisely, as Nick likes to say, is still an important part of this. But getting that coronary ID card early on is definitely going to save lives and prevent progression to bad disease.
What else? Any other things you guys would like to add?
I do want to make one other quick point, if you allow me. The companies are getting smarter about this. They understand that the cardiology market is a growing market and there's a huge demand. So they are making scanners that are more appropriate for office-based or for outpatient cardiology assessment. The price points will still turn your hair gray. Yeah. And it's good that I have a good hairdresser. Yeah. But I think that they are getting smarter about this, and the scanners are getting better. So, you still have to pre-med the patients. You still have to be careful about how you position them and all the other things that go along with it. For our audience, getting a good quality CTA is much more difficult than getting a good quality SPECT scan, treadmill test, or PET CT. So, if you're going to be integrating this into your practices and you haven't done it before, you will have a learning curve. But the companies are helpful with that also. Those are things that I think are important points, Jude, for people that are considering adding. I don't want it to dissuade them. I just want them to understand that, the landscape is changing, but the technology is something we're not used to, although Lance is. And, getting a good scan does take a little bit more work.
Well, thank you both very much. This has been a very entertaining and mind-blowing discussion. I appreciate y'all very much for doing this. I think we touched on a lot of great subjects, and hopefully we've brought some others to the forefront of what this AI tool can do and what it can mean to our platform at CVL. So, to our listeners, thank you for tuning in circulation from Cardiovascular Logistics. Be sure to subscribe so you don't miss future episodes as we continue to explore the innovations and insights shaping the future of cardiovascular care. Again, thank you both.